Cancer Actions webinar, Is the C in DCIS Really Cancer? Thank you so much for joining us today. My name is Leslie Riddle, and I'm the Program Officer at Breast Cancer Action. Joining me on the webinar today will be Dr. Shelley Hwang, Chief of Breast Surgery and Professor and Vice Chair of Research at Duke University Department of Surgery. A few quick announcements before we get started. First, Breast Cancer Action doesn't take any money from any corporations that profit from or contribute to the breast cancer epidemic. Our work is largely supported by individual donors like you. Please consider making a $25 donation today to support work like these educational webinars. Our presentation of Is the C in DCIS Really Cancer will last about 30 minutes. At any time during the webinar, you can ask a question by typing it into the question bar on your right-hand side. We'll save time at the end to answer as many questions as we can. Just an FYI, everyone except for the presenters will be muted during the presentation, so the background noise is cut down and we can all hear well. We want you to get involved with Breast Cancer Action. This webinar is a great way to do that. Please stay tuned for other ways that we'll mention later on in the webinar. Somehow my slide got switched over here. We're back to the agenda. I want to talk a little bit about what we're going to be discussing today with Dr. Hwang. So on today's webinar, Dr. Hwang will describe what DCIS is, what happens when people are treated for DCIS, and whether there's evidence for overtreatment. She'll also discuss options for management of DCIS, including usual care and active surveillance, as well as our ongoing study comparing invasive cancer rates, cystectomy rates, survival endpoints, and quality of life endpoints between standard care and surveillance groups. She'll wrap up by talking a bit about what the future holds for individual treatment of DCIS. And then I'll conclude our talk today by providing some further resources for information on DCIS. And of course, we'll have time at the end to answer your questions. Great. So before we launch into the webinar today, I just want to talk a little bit about the mission and vision of Breast Cancer Action. So we were founded in 1990 by a group of women who were living with breast cancer, who were frustrated with the lack of information about breast cancer. And, they saw a need for community that just wasn't there. They founded Breast Cancer Action because they saw a need for a grassroots organization with a unique understanding of the political, economic, and social context of breast cancer. Our founders, only one of whom is still alive today, knew that their private medical crises were part of a larger public health emergency, and that the experiences of those dealing with breast cancer needed to be heard to address this crisis. Breast Cancer Action is the only organization that addresses the breast cancer epidemic at the intersection of breast cancer, the environment, social justice, and feminism. Our mission is to achieve health justice for all women at risk of and living with breast cancer. So I'd also like to take just a quick moment and talk a little bit about sort of the core values that guide all of the work that we do here at Breast Cancer Action. So we believe that health justice is a human right. We believe in honesty, fearlessness, and truth-telling about the breast cancer epidemic. And we believe in honoring women's diverse voices and lived experiences. We also believe in putting people's health and well-being over corporate profits. And we believe in transparency and accountability for ourselves and for others. We also believe in collective action that changes the world for the better. And last, we have integrity and freedom from conflict of interest. We recognize here at Breast Cancer Action how issues of health and social justice are intertwined and form a foundation for our core values and work in ending the breast cancer epidemic. That's why we made a clear commitment to social justice as a foundation for all of our work. And I'd like to talk just briefly about what that means for us as an organization. So first, we do know that breast cancer and the breast cancer epidemic really impacts communities unequally, and that leads to kind of unacceptable differences in who develops breast cancer, when it develops, and of course who gets high quality and timely treatment, as well as who dies from breast cancer. We also know that in order to address and end the breast cancer epidemic, we must tackle the root causes of these health inequities, which are often the result of a complex interplay of culture, power, economics, racism, and sexism. We also believe that no single injustice can be effectively addressed in isolation, and we recognize that injustices in our society reinforce each other in many ways and at many levels. And last but definitely not least, in our work for health justice, we really strive to be an ally by using the power and privilege we hold as an organization to build solidarity with communities who currently or traditionally have less access to power, information, and resources. So that's a lot, about kind of the values that undergird the work that we do here. And I want to talk just really briefly about some of the issues that we do focus on here. So as the watchdog for the breast cancer movement, we work to educate, organize, and take action for systemic change in 3 distinct areas. The first is our work on breast cancer screening, diagnosis, and treatment, which examines the data from a patient perspective and includes breast cancer screening, healthcare access, drug and device approval, and demands more effective, less costly, and less toxic treatments. The next is our work around root causes of the breast cancer epidemic, which focuses on eliminating the involuntary exposures to hazardous and toxic chemicals present in all of our daily lives that put us at an increased risk of breast cancer. And the last is pink ribbon marketing and culture, which we feel often exploits a disease that devastates communities, misrepresents who's affected by breast cancer, and excludes and marginalizes women's diverse lived experiences of the disease. We address the true impact that breast cancer has on women's lives and on their communities. All right, so thanks for taking some time to learn from me about some of the work that we do and the values that Breast Cancer Action holds. I want to go ahead and introduce our wonderful guest speaker today, Dr. Shelley Hwang. But before I hand it over to her, I just want to tell you a little bit more about her. As I mentioned, she's the Chief of Breast Surgery and Professor and Vice Chair of Research at the Duke University Department of Surgery. She leads translational research activities in early stage and in situ breast cancer at Duke. Dr. Hwang has received local and national recognition for her clinical expertise and her research to improve both cancer and quality of life outcomes in patients affected by breast cancer. She was recently named in Time Magazine's 100 Most Influential People for 2016 as a pioneer in her field. Welcome, Shelley. I'll go ahead and turn it over to you.
Hi, Leslie. Thank you so much for that introduction. Can you hear me?
I can hear you.
Okay, great. So why don't we go ahead and just switch to the next slide. First of all, I'd like to thank all the participants on the call for taking time out of your schedules to be on the call with us. I hope in the next half an hour or so you'll find this information interesting, possibly even relevant to something that you're going through currently. I'm really interested in making sure that we have some time at the end for questions. So we'll dive right into it. The date for this is January 2017 because we had a very similar webinar last month, which was very well attended, but Leslie tells me that we have almost 8 times as many people on the call this time. So I'm super excited, and again, I hope that you find this information helpful. Next slide, please. So just for context, I think we should start out talking about how DCIS affects patients, because it wasn't a disease that was even recognized until quite recently, and it wasn't part of what most of us talked about when we were discussing breast cancer. But certainly over the last 10 years and possibly even more ramped up in the last 5 years, there's been a growing recognition internationally about the importance of this subject and how it affects women. So I just want to share with you a story that was published in the New York Times in 2010, which really started focusing media interest on this story. And this is a little bit of just a narrative about a woman whose name was Monica Long, 49-year-old divorced mother of 3 girls who went for her annual mammogram. This is usually the way things start. Some abnormal calcifications were found on the mammogram, which is the presence of little white dots. And based on this suspicious finding, a biopsy was performed and a diagnosis of DCIS was made. The patient was advised to undergo a lumpectomy and radiation, which she did. And then the following year, she moved to another state, and when she reinstituted her care, she resubmitted all of her films and her pathology slides. And at that point, she was told that she actually had never had DCIS, had never had cancer, and possibly had not had to go through any of the treatment that she initially had. So next slide. So I think this story brings up a few really important points that are part of the ongoing debate about what we do about this disease. So the first question is, did she even have a breast cancer in the first place? And then related to that, did she need any treatment for whatever condition she had? And then I'd like to focus the last part of my talk to, are there alternatives to managing what we currently do with patients who are diagnosed with DCIS? Next slide. So let's spend a little bit of time talking about what DCIS is. Next slide. And for all of these discussions, I think just for context, it's important to discuss how prevalent it is, so how many people are diagnosed with this condition. So DCIS stands for Ductal Carcinoma in Situ. It's also called a precancer or a pre-invasive cancer. It's called many different things, but when a diagnosis is made, the vast majority of providers in this country and in many other countries treat it as a cancer. They use the same sorts of words that they describe cancer to describe DCIS. The estimated incidence of DCIS is about 50,000 new cases every year in the United States, and it's estimated that about 500,000 women currently living in the United States have been impacted by a diagnosis of DCIS. DCIS is a perimenopausal disease in that most women who are diagnosed with the condition are somewhere between the ages of 50 and 60. And just as in that story that I started the discussion off with, it's usually diagnosed in women who are doing exactly what their doctors recommended that they do. They went for their routine screening mammograms, had completely no symptoms at all, and in one day their world is completely turned on its head, and now they're thinking about a cancer diagnosis and having to grapple with all their choices and making decisions about what to do. Now, there are many cancers that are diagnosed on the basis of mammographic screening, and this is not to say that all mammograms are bad. But what DCIS is an unintended consequence of mammographic screening, where we didn't set out to diagnose more DCIS, but in picking up more early stage breast cancers, we now have the capability of picking up more of these pre-invasive cancers. So these very early conditions that are diagnosed before it has a chance to become a cancer. Next slide. So I think it would surprise many of you to know how little we actually have found about what DCIS actually is. Next slide, please. And this slide summarizes a little bit about what we're starting to understand just based on some of the really exciting research that's being done in this field. What we think we know currently is that the progression from a normal duct, which is way over on one side to the left, to invasive cancer, which is way over on the right, is a gradual process. And there's no point in time where one day a patient has a normal duct, so the ducts are the tubes that carry the milk that's produced in the breast out to the nipple. There's no point in time where a normal duct overnight all of a sudden becomes benign proliferative change, and then at some point becomes atypical hyperplasia, and then at some point becomes ductal carcinoma in situ. These are, various shades of gray, if you will, if you don't mind me using that analogy, but it's not like all of these stages are very specifically defined. And in fact, there's quite a bit of variation in how pathologists interpret what they're seeing on the slides, which is how you get into the scenario that was exemplified by that story that I shared with you earlier on in the talk. So because the diagnosis depends on the appearance of the ducts, and because the appearance is assessed somewhat subjectively by a pathologist, there's often controversy over whether a patient has ductal carcinoma in situ or whether she has something that was one step before, which is an atypical hyperplasia. it's really important that you understand that there is this discrepancy in pathologic diagnoses with DCIS because the treatment recommendations are all based on what the pathologist diagnoses. And the treatment for atypical hyperplasia currently in the United States is completely different from the treatment of ductal carcinoma in situ. What we do know is that during this process of evolution from a normal duct lumen to invasive cancer, the ducts undergo various different kinds of changes. Some are genetic changes, some are additional changes to the DNA in the breast cells, and it can happen due to many different types of exposures, both exposures from your own body, such as hormonal exposure, but also exposures in the environment, such as radiation, certain compounds that are estrogenic in the environment, such as PPA, for instance. There are many compounds that have been found to have some impact on this progression from the normal duct to development of ductal carcinoma in situ. Now, the transition from ductal carcinoma in situ to invasive cancer can occur over a very long period of time, a short period of time, or might not even occur at all. But we, at this point in time, are very much struggling with trying to identify those ductal carcinoma in situ that would never become invasive cancer from the ones that would likely progress if we didn't do anything to treat it, which is really the underpinning of why the community has decided that the proper treatment for DCIS is to proceed with surgery. Next slide, please. So the current treatment of DCIS falls under NCCN guidelines. So there's a guideline committee that helps doctors taking care of patients with breast cancer to decide what the appropriate treatments are for a woman with breast cancer or DCIS. And right now, the currently published guidelines is that once a woman is diagnosed with DCIS, she has 3 options. The first is to have a lumpectomy with radiation. So lumpectomy is when a part of the breast is removed, not the whole breast. The second option is to have the whole breast removed. That's called a total mastectomy. And then the third option is to have a lumpectomy with no radiation. And there's very little guidance given about whether a patient should have one or the other. But the driving force behind most of these treatment decisions is what the patient herself feels is the best treatment for her. Now, I told you that sometimes pathologists have a bit of difficulty telling the difference between ductal carcinoma in situ and the condition that immediately is before that, which is atypical hyperplasia. The treatment for atypical hyperplasia is really some sort of hormone blocking therapy and monitoring. But you can see that the treatments that are recommended for DCIS are very different from that. Next slide, please. So when we treat patients with these standard recommendations, and we either treat them with a mastectomy, lumpectomy without radiation, or lumpectomy with radiation, patients have an excellent outcome. And I'll share that with you on some subsequent slides. But I think this slide just illustrates what has happened to treatment choices between 1990 and 2010. And if you look over the last 2 decades of what's happened with DCIS treatment, there are a lot fewer women who are getting unilateral mastectomy, so removal of one breast. But bilateral mastectomy, which was virtually unseen back in 1990, has now increased to 8% of the population of women who are diagnosed with DCIS. And about half of the women who are diagnosed with DCIS end up having a lumpectomy with radiation. So that represents quite a large burden of treatment for patients who have just a lumpectomy. That might not be that different from having a breast biopsy, but for those patients who have a bilateral mastectomy, they can be left with lifelong side effects from surgery and possibly reconstruction, including infections and pain and nerve disorders that can be with them for a long time and possibly the rest of their lives. Next slide, please. So let's talk a little bit about what the consequences are once a patient has treatment, which is standardly recommended for DCIS. Next slide. I told you that with the standard treatments, there is no doubt that patients do very, very well. So if you look at the overall survival of patients who are diagnosed with breast cancer over the age of 70, there is a little bit of a difference of whether you make it to the next 10 years based on what kind of treatment you have. But that's not because the treatment impacts your overall survival, because if you look on the right panel, no matter what kind of treatment you have, if you survive 10 more years from the age of 70, your likelihood of dying of breast cancer, which is the only thing that treatment of DCIS can prevent, your likelihood of dying of breast cancer is pretty much the same whether you have a mastectomy, lumpectomy with radiation, or lumpectomy without radiation. So if you tease this apart a little bit, it's a little bit curious that no matter how aggressively we treat DCIS, there appears to be no significant impact between these three standard treatments, which makes us start to question what would happen if we didn't treat patients at all and we just offered them monitoring and only treated them if they developed invasive cancer. Next slide. And the reason that we're interested in those questions is because we know that after treating patients with DCIS, they do have some long-term consequences. So there are some studies that are now starting to be published looking at some of the side effects of surgery for breast cancer, and this is one of the best ones that I know of, and that was published about 10 years ago. And this is a Danish study that looked at over 3,000 women who had surgery for breast cancer. Next slide, please. And if we look just at two groups of women, so if we look at those in that second red box that says BRT without chemotherapy, those would be women who had a lumpectomy without chemotherapy. And then the last group would be the patients who had mastectomy without chemotherapy. So these would be the two groups that are very similar to the kinds of treatment that patients with DCIS would get. And when we asked this group of patients what percentage of them actually had pain, and this was within 3 years after treatment, about 40% of those with a lumpectomy and 25% of those who underwent mastectomy reported having some pain. And about 10% of those having lumpectomy and 3% of those having mastectomy reported that it was actually severe pain. And about a third in each of the groups reported having some sensory disturbances, some nerve pain, tingling, altered sensation in the breast, and it can include things like numbness, for example, where the incision was made. Next slide, please. So there are clearly some long-term physical consequences that women have after breast surgery, which I think any surgeon is has a responsibility to discuss some of these long-term side effects with patients who are contemplating having surgery for their disease. But the other even less well-defined consequence that women can have when they undergo treatment for DCIS is the anxiety and kind of psychic consequences of having this sort of treatment and having been diagnosed with a condition that feels like cancer to them. So this was an interesting study that was published about 5 years ago, and it compared anxiety following diagnosis in women who had DCIS to those who had a stage 1 invasive cancer to those who had a stage 2 invasive cancer. And the dark gray bars represent the percent of women who had high levels of fear, so fear of cancer, fear of dying of cancer, and the white bars represent moderate levels of fear. And remember, I told you with all of the standard treatments that we recommend for women, they have about a 98% chance of not dying of breast cancer in 10 years. So it's highly unlikely. You'd have to be pretty unlucky to be diagnosed with DCIS and treated for it and still go on to die of breast cancer. But when you look how much people worry, the percent of women who actually have moderate or high levels of fear after a diagnosis and treatment for DCIS is actually higher than women who are actually diagnosed with an invasive cancer and start getting close to the levels that you see with a stage 2 invasive cancer. Next slide, please. And I apologize for this slide, and you can see many different iterations of this sort of thing on the internet, but I think no matter what you read and what you hear about patients wanting to have both of their breasts removed because they want to have better looking breasts after bilateral mastectomy, despite our best efforts and the best technology that we have, we still have patients who don't have an ideal outcome. And as the patient going into this surgery, it's really hard to get an accurate understanding of what you're going to look like on the other side. Next slide, please. So I'd like to spend the next part of the talk just discussing what sort of rationale is there to justify treating DCIS less aggressively and possibly thinking about omitting surgery altogether in some subpopulations of patients who have DCIS. Next slide. Well, it all comes back to mammography for me, because before women underwent routine screening mammography, DCIS was something that was hardly ever diagnosed. It was always there, but we just really had no way to detect it because DCIS wasn't something that you could actually feel as a lump. And so when we started doing mammograms and picking up these white dots that were very obvious on a mammogram, we as a medical community felt that this was something that we needed to make sure that we treated. Next slide, please. And I think that the next slide makes the point that your biggest risk factor for developing DCIS is having a mammogram, because you can see that the incidence of DCIS, so the number of newly diagnosed DCIS in the country between the years of 1980 and 1999 exactly paralleled the number of mammogram machines in the country. So as screening mammography became more widespread and everyone adopted the Pink campaign and got the word out and got their family and friends to go for their mammograms, yes, some cancers were detected early and therefore some lives were saved. But on the flip side, we ended up diagnosing much more DCIS and treating it with unclear benefit to the patient. Next slide, please. Now, why do I say that there's unclear benefit? Well, there are other examples of other cancers, next slide, where we screen for the cancer, and after we institute screening, not only does the incidence of that cancer go down, so not only is there a lower incidence of cancer over time, but the mortality from that cancer also goes down. So this is an example of cervical cancer screening. So cervical cancer screening was instituted in the 1980s. And initially, there was a high incidence of cervical cancer, but that started to go down over time, and the mortality also dropped, which makes us feel that the screening actually had an impact on the mortality that women experience from cervical cancer. Next slide, please. The next is a kind of a busy slide, but if you'll just stay with me. This shows colon cancer incidence and mortality rates over a long period of time, and I think it's really only the right side of the panel that you're interested in, because this starts from 1930 and goes to 2010, and I know most of us were not alive in 1930. So if you look at the four curves that are on the right side of the slide, there's incidence of male colon cancer, incidence of female colon cancer, incidence of mortality from male colon cancer, and mortality from female cancer. That's what those curves show. Colon cancer screening was instituted in the 1990s. And when we screen for colon cancer and remove the polyps that were considered the one step before becoming cancer, we were able to reduce the number of new cancers that were diagnosed. And by reducing the new cancers that were diagnosed, we were able to reduce mortality from colon cancer. So that all makes a lot of sense, and it's all entirely in keeping with what we saw for cervical cancer in the previous slide, where we started to do more pap smears. We diagnosed these early conditions and got rid of them. So we found fewer invasive cancers and then fewer deaths from invasive cancers. So both of those scenarios completely make sense with what screening is supposed to do. Next panel, please. It's a little bit different from what we're finding in the DCIS scenario, though. because as we're diagnosing more and more DCIS, the incidence of invasive cancer, which should go down if you're taking out all of the pre-invasive cancers from the system. But even though we're diagnosing and treating more DCIS than ever before, at least up to sort of the 2000s, the incidence of invasive cancer did not look like it was going down, except when women stopped taking hormone replacement therapy. That did cause a little bit of a dip in the incidence of invasive cancer or new breast cancers. So this is a scenario that's a little bit different from what we've seen for screening for cervical cancer and colon cancer. And this is the kind of evidence that shows that even with the increased detection and removal of DCIS, it really hasn't translated into a reduced incidence of invasive cancers. And there have been some efforts to model the impact of mammography on mortality from invasive cancer, and there's probably been a much greater impact of treatment advances than there has been benefit from screening mammograms. Next slide, please. So I think it begs the question, what would happen if we did not do anything about the DCIS? So we accept that we're going to see it on the mammogram, but what would happen if we didn't do everything that we can to remove that condition that we see on the mammogram? So there really isn't much data to show what would happen. There are probably about 200 cases reported in the world's literature to describe what would happen in patients who had DCIS, but their pathologist didn't recognize that it was DCIS at the time that it was diagnosed. So when you go back and retrospectively look what happened to these women who didn't know that they had DCIS and so they weren't treated for their DCIS, we can see that their long-term risk of invasive cancer is not 100%. So if you leave women with a DCIS diagnosis and we don't treat them, then in the next 20 to 30 years, only about 20% or so ended up developing invasive cancer. Now, that's not to say that that's a low risk, but it's just to say that it's certainly not the 100% that you would have expected based on how we're currently treating the disease. Next slide. So I think if we delve further into this subject, it's really important to think about, well, what would the downside be if we waited until invasive cancer developed before we decided to do any surgery or intervention for DCIS? Next slide. And because there are not thousands of women who've decided to make this decision of not treating their DCIS, we have to go to the next best thing, which is to model what the outcomes would be based on some of the things that we know about how cancer can progress. And I'm going to spend a little bit of time talking about the next few slides, but hopefully you'll understand why this is really important to do. Because when you compare usual care, which is what we currently do, we operate on patients and half of our patients get radiation, and we compare it to active surveillance, which is close monitoring and treatment only if the patient were to develop invasive cancer. Next slide. It's really important to know what impact this sort of strategy has on things like how long you're likely to be alive in 10 years and how likely you are to die of breast cancer at 10 years. So I'll walk you through the next slide in some detail, and then hopefully you'll be able to follow along. So this is a modeling exercise of women who are age 40 at the diagnosis of DCIS. The dark black line shows the likelihood of a patient at 40 dying of breast cancer if the DCIS were not treated. The red line is the patient's likelihood of dying of breast cancer if the DCIS was treated according to how we usually treat DCIS. And then the blue line, which is also very important, is this patient's likelihood of dying of any other cause in the next 10 years. Now, the gray shaded area just indicates that there's a big amount of uncertainty. So if you see a patient in the clinic, there's no way that any doctor can ever tell you you have a 22.3% likelihood of developing cancer in the next 6.8 years. It just doesn't work like that. Because all patients are different, all DCIS is different, there's going to be an estimate and then what we call a confidence interval or some sort of uncertainty around that estimate. So if we look at the gray shaded region and we look at 10 years, the lowest likelihood of dying of breast cancer based on that black line is 2% and the highest likelihood is 6%. And the truth is probably going to be somewhere in between. Next, go ahead. So the gray shaded area shows that the truth will end up being somewhere within that gray area. 95% of the likely outcomes would fall within that gray area. Next slide. And 95% of what would likely happen if a patient got treatment for their DCIS would fall between those two sets of dotted red lines. Next slide. And 95% of the things that could happen to a patient in the next 10 years in terms of whether they would die of a cause other than breast cancer would fall in between the two sets of dotted lines. So it's a really long explanation, but hopefully that it'll make sense when we go on to the next slide. So if we take a woman who's age 40 at diagnosis, their likelihood of dying of any cause within the next 10 years is very, very low because women at 40 are healthy. They have no significant medical conditions for the most part, so their biggest risk is going to be the risk of dying of breast cancer. So if we were to only treat the patient's breast cancer if they developed invasive cancer, then their likelihood of dying of breast cancer would be 2.6%. So if we only monitored their DCIS, then they'd have about a 3% chance of dying of breast cancer. If we treated DCIS at the time that it was first diagnosed, then they would have a 1.4% chance of dying of DCIS, of breast cancer. So the difference of what would happen if you monitored the DCIS and only treated if it became breast cancer versus if you treated it up front at the time of diagnosis, that difference is only going to be about 3% at 10 years, which is still a big enough percent that I think we can definitely justify treating patients with DCIS if they're diagnosed around age 40. Next slide, please. Now look what happens at age 50. So a patient's likelihood of dying of breast cancer, if you have monitoring, goes down. And a patient's likelihood of dying of causes that are unrelated to breast cancer go up. So your risk of dying of something unrelated to breast cancer is higher than your risk of dying of breast cancer if you are not to have your DCIS treated. Next slide, please. And this is even more apparent if you look at women who are age 70 at diagnosis, where no matter what you do in terms of their DCIS, whether you choose to monitor their DCIS or to treat their DCIS, their likelihood of dying of breast cancer is very small because their overwhelming likelihood of dying in the next 10 years is due to things that are completely unrelated to breast cancer, like heart disease and other cancers. Next slide, please. So I think not only does an individual need to balance some of these trade-offs, but the system as a whole needs to balance these trade-offs too. So if you look at what we're doing as a health system in the United States, and we look at what we do in the interest of helping women, so nobody does this because we want to overtreat patients. And I really believe that the majority of doctors out there really believe that they save lives by treating patients who have DCIS. But what this looks like is that about 34,000 women will have lumpectomy, 23,000 women will have radiation, 10,000 women will have a mastectomy, most of them will have some kind of reconstruction, and about 4,000 women will have mastectomy on both sides. And a conservative estimate of how much all of this costs is about $250 million annually. Now, compare that to what would happen with active surveillance, where you don't do any of this unless a patient develops invasive cancer. And the trade-off for that is about a 1% difference in dying of breast cancer, whether you have a monitoring strategy or an immediate treatment strategy like we currently have. Now, I was very surprised when this webinar was advertised or the notification went out, and immediately there was a little blip of interest, and bloggers kind of got on the, started blogging about this subject, and I was really taken aback because one individual accused me of not caring about women's health, and all I was trying to do was cut costs, and that really could not be any further from the truth. But I think when we talk about interventions that can potentially hurt women and potentially not benefit them in terms of their breast cancer risk, I think we need to be very mindful of what we're doing, how much we're doing, and how much resource allocation goes to those sorts of activities which may not help women substantially at the end of the day. Next slide, please. So I'd like to spend the last 5 minutes or so talking about how I envision the future for patients with DCIS. Next slide. And I think it starts with understanding the biology of DCIS much better than we did 40 years ago when we first started treating DCIS in pretty much the same way that we're treating it now. So just as there are many different kinds of breast cancers, there are many different kinds of DCIS. And from what we're starting to learn, the different subtypes of DCIS has different outcomes. So it makes sense that there are, just as in invasive breast cancer, those DCIS that are going to be bad actors, and you wouldn't want to monitor them because they have a high risk of developing to invasive cancer during monitoring. But equally likely, there are going to be those very good actors that even if you monitored them for the rest of the patient's life, the high likelihood would be that the patient would die of something else and not breast cancer. So it all goes back to a better characterization of what the cancers look like. Next slide. And even though this is a very new idea in breast cancer, it's something that's been around for at least 20 years in prostate cancer. And earlier, well, I guess it's last year already, in the New England Journal, there was this study that compared 3 different treatments for early stage prostate cancer. Next slide. And the 3 different treatment groups that patients were randomly assigned to was a surgery, that was a prostatectomy, radiotherapy, which is radiation to the prostate, or active monitoring, as we've been talking about today. And when we look at the likelihood of patients dying of prostate cancer in 10 years, there was absolutely no difference between the 3 groups. So even though this feels unfamiliar and scary for us in the breast cancer world, it's something that people have gotten very comfortable about discussing and considering in prostate cancer. And remember, these are men who actually had invasive cancer, not precancer like we see in DCIS. Next slide. And there actually are some preliminary data that show that if we look at women, those rare women who chose not to have surgery for their DCIS, certainly in the group of women who had the most favorable, least aggressive kind of DCIS, there's virtually no difference between those women who had surgery, who had a 98.8% likelihood of living for 10 years without breast cancer death, or those women who had no surgery, and these patients had a 98.6% likelihood of not dying of breast cancer in 10 years. Next slide. So we are starting to put our money where our mouth is, and although we've been talking about different kinds of surveillance options for DCIS rather than treatment, we finally got the opportunity to actually put this to the test. And this is really the gold standard of how we advance treatments for women for breast cancer and all other cancers, which is to design a clinical trial that's going to test 2 different ways of treating a disease. And in this case, we want to enroll women who have very favorable, not aggressive DCIS, and we will randomize them to 2 groups. One group with 450 patients will have what we usually recommend to patients. They'll have surgery, radiation, or both, and then they'll be followed. The other group, which is the experimental group, if you will, will just be followed with close monitoring. They'll have mammograms every 6 months for 5 years. We're strongly encouraging that these patients consider taking a hormone blocking medication because we feel that that will slow or obliterate the progression of invasive cancer. And we only treat these patients if they develop invasive cancer. Next slide. And we'll be interested in collecting not only how patients do long-term in terms of their cancer outcomes, but how it feels to be a patient with DCIS on the study from the point of view of how scared are you, how anxious are you, what kind of pain are you experiencing, what kinds of other symptoms are you having, was there a significant financial impact to being diagnosed with DCIS and having treatment for it? How do you feel about your body? How do you feel about your sexuality? This is all really important information that will help us to balance the trade-offs of treating patients right away for DCIS versus waiting until they develop invasive cancer. Next slide, please. So the way that this will look is if a patient has DCIS, which is a favorable kind of DCIS diagnosed on core biopsy, we'll introduce the trial, and if the patient's not interested, then of course they'll just have standard treatment. If they are interested in the trial, then they're agreeing that they're okay to be in one or the other group, so they can't choose to be in either one group or the other. And those patients will be one-to-one randomized to either the group that gets standard treatment or the group that gets active surveillance. Next slide. And this is really busy, but basically, if a mammogram changes during the time that a patient is being followed, and that will happen for all the patients on the study, no matter whether they had surgery or not, a biopsy or further workup will be recommended. And if the biopsy ends up showing invasive cancer, again, no matter which group you're in, then we will recommend a treatment that we would standardly give for invasive cancer. So you're not burning any bridges. There's certainly no limitations in terms of the kind of treatment that you would get if you were to develop invasive cancer. Next slide. So you don't have to pay too much attention about all the details, but usual care, so this is what we usually do on the left, and active surveillance is on the right. And if we look at 1,000 women who we treat with usual care, then all those different colors recommend some kind of treatment that women are going to be getting. On the other hand, if we look at active surveillance, all the white means the treatments that patients will be able to avoid by following a strategy of active surveillance. Next slide. But that doesn't matter if you're increasing the likelihood that you're going to die of breast cancer. And we can model this out, and provided that the patients develop a non-aggressive early stage form of breast cancer, then the likelihood is that patients can be cured of their breast cancer with probably the same types of treatments that could be applied to patients who are diagnosed with DCIS. So that's the concept. Next slide. And of course, we're very interested in understanding which patients go on to develop invasive cancer and which patients never develop invasive cancer, even in the absence of any treatment. And so we'll be collecting blood and tissue from all of our patients who want to participate in the study, because we really feel that the future of where this is headed is understanding more about the tumors. We're going to do genomic sequencing on all of these different specimens, and hopefully this will reveal the group of patients who are at such low risk that we don't have to treat them with all the invasive treatments that we're giving to them currently. And I guess this is late breaking news, but last week it was announced that our team, which is an international team including the Netherlands, a group in Cambridge, and a couple of institutions in the United States, including Duke and MD Anderson, we are all participating in a $50 million grant, which will help us characterize all of these tumors in a much more detailed way than we were ever able to do before. So clearly, people are recognizing that this is a very, very important issue and one that we really need to understand better. And that it's not okay to continue treating patients with very aggressive treatments because we don't know what the alternatives are. Next slide. I think before we end, I just want to make the point that not all patients are candidates for active surveillance. And as I mentioned before, patients who have aggressive disease or very extensive disease that covers the whole breast, these are not patients that we would just want to monitor. Also, if patients have a lump, that's a strong indication that they may also have invasive cancer. And if they have other symptoms such as skin changes or bleeding from the nipple, these are all much more worrisome symptoms that patients can have invasive cancer. And so I would encourage anyone who may be in a position to think about surveillance yourself or giving advice or supporting someone who's going through this diagnosis. This is an unknown, uncharted waters that we're going into, and so surveillance would not be encouraged outside of this clinical trial. But fortunately, we have a clinical trial which will be opening this month that people can enroll in. Next slide. So just a couple of concluding slides here. I think I've shared with you that DCIS is here to stay, but not because we ever set out to find DCIS. It's an unintended consequence of what we're finding with more breast cancer screening. And the kind of treatment that we recommend for DCIS right now is based on how large the area of DCIS is, but more importantly, what patients choose. And the current treatments are very effective in preventing invasive cancer. But women do so well that I think there's a lot of question in the community about whether they're doing well because they never needed treatment in the first place, or whether they're doing well because the treatments are so effective. Next slide. So we're in a position where we can start testing out this new alternative strategy of waiting until a patient has a problem before treating. And I would just mention that you hear personalized therapy so much, and it's usually in the context of giving more treatment. But if we're really going to be personalizing therapy in the future, we really need to have the courage of dialing back on those treatments that don't look like they're very effective in helping patients. I think to make these kinds of decisions and to be able to give advice to the patients of the future, we really need to better understand the trade-offs, both from the cancer point of view and the survival point of view, as well as what it feels like personally to be a patient who's undergoing some of these treatments and making some of these decisions. And I think clinical trials like the one that I showed you, and then there's another trial in the UK and one in the Netherlands that compare surveillance and monitoring with surgery and radiation, will help us to come up with a better understanding of what you're giving up and what you're gaining by having usual treatment for DCIS versus active surveillance. Next slide. So I wanted to thank you all again for your attention. This is obviously a subject that's very near and dear to my heart. My interest in this idea really started from my first year in practice when I was out seeing my very own patients. And I remember a woman who was 40 when she was diagnosed with DCIS, and she decided to have a mastectomy. And I can just tell you, for the 10 years that I followed her after that, that really was a very huge impact on her life, and it really impacted her in so many ways. And it made me really start questioning whether we have our patients' best interests at heart by treating everyone who comes in the door with this diagnosis. So hopefully you found this interesting. I think there is some capability of maybe asking some questions. And Leslie, I don't know if you can give some instruction to people to submit their questions.
Great. Yeah, thanks so much, Shelley. This was a wonderful presentation, and definitely want to get into answering some of your questions that have come in, and you're more than welcome to continue to submit them, and we'll try to get to as many as we can in the few minutes that we have left. But before we launch into questions, I do want to just touch on a few resources where you can learn a little bit more about DCIS. First is Breast Cancer Action's DCIS fact sheet that is available on our website if you click on the link. And you can also get more information on Dr. Hwang's COMET study. The link is included here. And for any listeners who are interested in potentially enrolling in the study, please shoot me an email, and I can try to link you up with the study coordinator. My email is lriddle@bcaction.org, and you should have my email on the materials that were sent to you for the webinar. So feel free to do that. And I also wanted to note that certainly there, tends to be a lot of questions about kind of individual medical situations and, folks who have been diagnosed with DCIS who have questions. And I know that, Shelley, you're not able to kind of give full, medical advice without knowing a full clinical history. But I think for any listeners who are kind of interested in potentially getting a second opinion or connecting with Shelley in that way, you can contact her office at Duke directly, if that sounds good. So I want to go ahead and also talk really briefly just about how you can join Breast Cancer Action if you want to get involved with us. And I hope after this webinar you are excited to learn more about the work we do and how you can get linked up with us. So you can become a member by signing up for our news and our e-alerts emails to keep up to date on all the issues that we're covering. You can join us on social media, on Facebook or Twitter, to connect with others and help, change the conversation about the breast cancer epidemic. And you can also help others get involved, spread the word, tell your friends, your coworkers, your family about this webinar and our future webinar series and how they can take action. And just want to note that we do record all of our webinars and make them available on our website. They're found under our Educational Resources tab. So we'll try to have the recording of this webinar up this week so you can go ahead and share it with others. And lastly, you can donate to support our education and advocacy work. I talked a little bit at the beginning about how Breast Cancer Action certainly relies on your support to make these webinars possible. So if you have been inspired today, please do consider making a donation of $25 or more so we can continue our educational programs, including these webinars. And that's at www.breastcanceraction.org/donate. So I do want to give a huge thank you to Dr. Hwang for her presentation today, and go ahead and open it up to questions, and we'll try to get to as many as we can in the next couple of minutes. So the first question that I have is, can a doctor determine your risk of invasive cancer based on your family history? Shelley, I'll direct that to you.
So that is a much broader issue and not specifically about DCIS. I think the quick answer is no, but I think that most people can give you some sort of general estimate of what your future breast cancer risk is likely to be. There are centers that have, Duke, for instance, we have a high-risk counseling clinic, and you can also talk to genetic counselors about that. And there are genetic tests that could help to, further refine your future estimates of breast cancer risk. So I would suggest you look into those resources.
Great, thanks. There have been some questions about where to find more resources or information on high-grade DCIS, and I know oftentimes your focus has been kind of low-grade. Can you talk a little bit about where folks might be able to get some more information on high-grade DCIS?
Yes, and you know why I love that question so much is that I think we've already started changing the discussion about thinking about DCIS as one disease, and we're starting to develop awareness in the community that it can be many different diseases with different potential outcomes and different treatments. So for those of you who submitted that question, I love it so much. Unfortunately, the treatment options for high-grade DCIS are pretty much the same as what we're offering currently. There are websites where you can get some really good, very objective information about what those treatment options are. Breastcancer.org is a particularly good one, and while I don't think that most patients should just go, Google DCIS, I think breastcancer.org does a really good job describing DCIS and all the treatment options. We ourselves, who are the study team for the COMET study, will have our DCIS website up in probably about a month or two, and that's going to be a clearinghouse for all sorts of different questions around all of the different kinds of DCIS. So we'll have that in a couple of months for you.
Great, thank you so much. And I'll just wrap it up with one final question. Could you say something about adjunct interventions or behavioral changes that may benefit or reduce your likelihood of progression of DCIS as part of the active surveillance plan?
Yeah, so I love that question, and there's not very much known about it, but we do have a patient advocate on the COMET study who has sort of made it a life's work to understand that better. I think stress reduction in terms of just mindfulness, yoga, those sorts of things can be extremely helpful. There are certainly dietary interventions that people have described, including just very common things like maintaining a healthy weight, exercising, reducing animal fats from your diet, and that sort of thing. I won't be able to give it justice, but even though there are not a lot of data about how you can prevent progression to invasive cancer, there still are many dietary and lifestyle interventions that can just improve your overall health as well as possibly impact that progression to invasive disease.
Great. Thanks so much, Shelley. So I want to thank you all for your questions and comments. If we didn't get to your question today, or you do think of one later that you'd like to ask, please feel free to follow up with us at info@dcaction.org. And also I listed out some resources before that hopefully you can tap into that will be useful to you. So thanks again so much for your time and attention. Please do watch your email for a brief survey. You can provide more feedback on this webinar, help make our program better and better each time. So thanks again, and thanks so much to our presenter, Dr. Shelley Hwang, and have a great rest of your day.
Thank you, Leslie. Really appreciated the opportunity.
Great.
Bye.
Thanks so much. Bye-bye.